All right, so today's topic is understanding fibroids, their diagnosis and their treatment. I'm a consultant obstetrician and gynecologist. I'm currently the head of department of OBGYN at the Nairobi West Hospital. So I've been in this practice for about 12 years, and I've had my studying here in Eldoret. I went abroad for some electives, and but I'm Kenyan, so I'm hoping to understand. I mean, I do talk very fast, so in case of anything, if I'm going too fast, please drop a chat so I can slow down. And please write down your questions so we can address them at the end of the talk. I really hope we will understand fibroids better after this presentation. I've tried to keep things very simple, but I know sometimes our medical terms can get away with us, so please bear with me and write it down. In case you need any clarification at the end of the session, I shall give it to you. We're going to talk a little bit about the introduction and the incidents so that we can understand how common this issue is. So uterine leiomyomas, which is also known as fibroids or myomas, are the most common pelvic neoplasm in females. So a neoplasm means it's a tumor, but these are non-cancerous tumors. I want to emphasize this is not cancerous. They're tumors, yes, but they are called benign tumors, and they're composed of smooth muscle and fibrous connective tissue of the uterus. So you have some cells in the uterus which just multiply unchecked. So anything that multiplies unchecked is called a tumor. It may be malignant, which is cancerous, and that's when it spreads to other parts of the body. But in this case, it's benign, which means that it just multiplies within its same position. They arise mostly in reproductive age females, and when symptomatic, they typically present with symptoms of and/or pelvic pain, pressure, and symptoms of heavy and/or painful bleeding, which also, I mean, it can be heavy and painful menses as well. Uterine fibroids may also have reproductive effects, in as much as they might not present with the above symptoms. Patients may experience infertility or adverse pregnancy outcomes. So the incidence of fibroids, usually more than 20% of women at 30 years of age will have fibroids, and these women are asymptomatic. You may not even know you have fibroids. You're walking around, you have fibroids maybe of various size, in various locations, in various number. And 3% of women in our OPD means outpatient department, they will come in as symptomatic fibroids. So that means in the gynecological clinic, we have the outpatient clinics in various places. So out of all the visits in an OPD clinic, 3% of women will come in with symptomatic fibroids. Unfortunately, it's a higher rate in Black race. So the fact that we're in Kenya in itself, we see quite a number of patients with fibroids. And it's more common in nulliparous women or in women having infertility after one child. Nulliparous means you have never had a pregnancy, whether to term or a miscarriage in your lifetime. The highest prevalence is noted between ages of 35 to 40. Now, at the end, you see in brackets number 4, those are my references at the end of the slide. If you guys want access to them, we can have it. I can share the slides with you. So the etiology means what causes these fibroids, right? It's actually unknown. Basically, they are immature muscle cells that are present in the myometrium and that have been found when a fibroid is cut open. That's what they find. We suspect excessive estrogens may be the culprit, as it is noted that fibroids or myomas grow during childbearing age only, and after menopause, the growth of the tumor stops or regresses in size. The growth rate is typically slow, and it may take about 3 to 5 years to be felt as a mass per abdomen. So for purposes of context, by the time a mass or a pregnancy is felt per abdomen, you're already 3 months pregnant. So 3 months, it's about 12 to 13 weeks. That's when As a gynecologist, as a doctor, we're able to palpate or feel your uterus from the abdomen. So you can imagine, by the time a fibroid is big enough for us to feel it, it's as big as a pregnancy of about 3 to 4 months. And very fast growth can be due to degeneration or malignant change. So if you have a fibroid that you did a scan maybe a month ago, and now a month down the line, it has really markedly increased in size, and you have confirmed that it is not because of operator bias. For example, the person doing the scan made a mistake. You might need further investigation into your fibroid. So what are the risk factors? I feel like I have touched on them a little already, but we'll go through them again. Several factors for having fibroids, which include the following. Age, of course. Older women are at a higher risk than younger women. Like we said, highest prevalence is between 35 to 40 years of age. African American race, in our case, basically being Kenyan. Well, not in not in terms of your. Sorry, yeah. So not in terms of your what your country of residence is, but basically in terms of race. Obesity will put you at risk of having fibroids. A family history of uterine fibroids, so it's very, very genetic. If you've had an aunt, your mother, your grandmother who have fibroids, you're at risk of getting them as well. High blood pressure, no history of pregnancy, which we talked about as being nulliparous. Vitamin D deficiency, food additive consumption, use of soybean milk, and factors that may lower the risk of fibroids. Pregnancy, the risk decreases with an increasing number of pregnancies. However, disclaimer on that, there was a couple of studies that showed that in pregnancy, a third of patients will have their fibroids increasing, while majority will have the fibroids remaining at the same size. So they can become very painful in pregnancy if they start degenerating, and that they might even regress in size, they might shrink in size. So like I said, majority will either shrink or stay the same. But you have a 1/3 population who might have an increase in the size of fibroids during pregnancy. And then long-term use of oral and injectable contraceptives. Again, my references are as below. So the signs and symptoms: heavy menstrual bleeding or painful period. What people say behind heavy painful periods, most people will tell you that painful periods are a way of life. It's you have to pass through it through if you're going through womanhood, but you always have to come in and have them checked. You might not be experiencing what is a normal painful period. There may be an underlying cause to the painful or a heavy bleeding. So you may also get longer or more frequent periods, in the sense that maybe you started off initially as having a 3-day period length, which now, as the fibroids are growing or increasing in number, they might increase to 4 or 5 or 6, 7 days. Again, up to 7 to 8 days is considered normal, as long as it's not heavy throughout. But if you're somebody who's bleeding for over more than that, more than 8 days, and you're getting your periods every 10 days or 15 days, before 15 days are over, you have another cycle starting, that is abnormal. So you might feel pelvic pressure or pain. What that means is you feel really heavy in your lower abdomen. You feel, some people will describe it as a feeling of carrying stones, and you might feel pain. The pain may be during sex, it may be when walking, it may be when sitting, it may be just when doing nothing. So any pain that you feel that is persistent is abnormal. You need to come in and get it checked. Then another symptom is frequent urination or trouble urinating. What that means is basically you'll feel the urge to pass urine, but when you go to the washroom, there's nothing that comes out. Or you might go, you empty your bladder and you feel like it's emptied already. You leave the washroom and within a few minutes, you feel the urge to come back and pee again. Then you may also feel a growing stomach area. Basically, you feel that mass. It's sometimes mimics a pregnancy in the way it grows. So people might suspect, I mean, other people, there are many women I do get in the clinic who have had no idea. They just think they're gaining weight until one or two of their colleagues ask them, are you pregnant? Your tummy seems to be growing like a pregnancy. And then when they come in, we find out actually it was fibroids that was making the uterus so big. So another symptom is constipation. Basically, the constipation, the pressure, the frequent urination, it happens because, well, the frequent urination and constipation is because the uterus sits between the bladder and the rectum. So when it grows in size, it displaces both. It will displace the bladder and it will displace the rectum. So you will have issues. It might put pressure on the rectum, not allowing it to empty like normal. And so that's why you get constipated, because the contents of the rectum are not moving, okay, because of this, the mass that is the fibroids. And so when it sits there for too long, you end up getting constipated. So another sign is also pain in the stomach area or lower back, or pain during sex, which we already talked about. Now, I want us to spend some time on this fibroid, or this on this slide. This is showing the location of fibroids, and what you're seeing is a cross section. So basically, it's as if somebody is looking straight at is facing your pelvis, and then we've cut a cross section of the uterus down the middle. Okay, so if you orientate yourself, on your right and left is your ovaries and your tubes, and then in between is the body of the uterus. What you see as the markings is a subserosal, there's an intramural, submucosal fibroid. So the fibroid will be named based on the position it has in the uterus. When you have it in the lining, if you see the first one, which is called the submucosal fibroid, that means it's indenting into the lining and it's more in the endometrium as opposed to the muscle of the uterus. Now, below the arrow pointing for the submucosal fibroid, you have what we call usually a pedunculated fibroid within the cavity of the uterus. These are very, they can be very annoying in the sense that if they grow so big, they might prolapse down into the cervix, into the vagina. Again, it can cause irregular bleeding, can cause pain during sex if it becomes big enough to protrude down. Then if you go lower down, on your left is written intramural fibroid. This means the whole fibroid is in your muscle. So there are three layers to the uterus. You have the serosa, the muscle layer, and the endometrial lining. So this intramural fibroid is just within the muscle of the uterus wall. Now, as you come lower, you have a subserosal fibroid, which means majority of the fibroid is outside the uterus, with just a little bit of the root, so to speak, inside the top lining of the uterus. A subserosal fibroid may be the one with the least symptoms, especially if it is small. And then on your right, you will see pedunculated fibroid. Again, this one will come with very, very minimal symptoms, because as you can see, it's taken part of the covering of the uterus and it's completely outside the uterus, hanging with a small, what we call a pedicle, like a sort of a leaf. How the leaf hangs onto a branch, this is how it's hanging out. And so it may not cause you heavy bleeding or painful bleeding, especially if it's small. However, if it's big, it can cause pulling of the uterus towards that side, sorry. So what you see down there is the cervix, and right below the subserosal fibroid is the cervix and the opening into your vagina. So diagnosis, many patients come and they get agitated that how do we know if we have fibroids or not? How do we go about investigating it, and what do we do next? So like I said, many women will be asymptomatic. It is not a cancerous lesion. You do not routinely need to go and look for it to see if you have the fibroids or not. You do not routinely need a scan unless you're having the symptoms that we talked about in the previous slides. So very important is the history. When a patient presents to you, the first thing that will start pointing you in the direction of a fibroid is the history. They may come in with painful or heavy bleeding. They may come in with painful sex. They may come in with history of a mass or some firmness in their tummy. Some people may also just present with bloating because they do not understand what is growing, especially if you're somebody whose BMI is on the higher side. Like we talked about obese women, you may not realize that there's something growing in your tummy. So you may just come in with bloating. So basically the history is a very important part of your diagnosis, as it helps guide you in what management you will do for this patient. A physical exam as well, many a times we can feel the uterus as per the abdomen by the time it is symptomatic. However, on the other hand, we may not also feel anything if the fibroids are not that many to have reached a size of a 3 to 4 month pregnancy, but they are symptomatic, you may still have come to the hospital. So the most important diagnostic tool for fibroids is a pelvic ultrasound. Let alone what, you have the expensive tests like an MRI, CT scan, but a pelvic ultrasound is your best screening tool for fibroids no matter how small they are. So like I said, if we're talking about history, if a woman is presenting to you with infertility, then you would need to do an HSG as well to see. So an HSG, the full terms for it is hysterosalpingogram. And what it's used for, basically, we push in a dye through your cervix into your uterus, and the dye goes out through your tubes and spills into the abdominal cavity. At the same process, we take X-rays because the dye is radio opaque. So it will, basically the X-ray will give you a tract, a path, the path that the dye will take. So if you have a fibroid that is protruding so much into your cavity, it will show up as a filling defect on the on the X-ray. If you have a fibroid that is blocking your tubes and not allowing your egg to come in and meet the sperm for pregnancy, you will see there's a blockage in the tubes. And that's where the HSG is helpful. Then you have something called a saline infusion sonography. Not many centers offer this tool, to be honest, and but it's a very good tool to identify if your tubes are open and if there's any fibroids. Again, you are injecting saline through the cervix of a patient, and you track the bubbles in that saline through your ultrasound to see if they are spilling out into your abdominal cavity. Then the last tool that we have to our disposal is an MRI. MRI is good for soft tissue, and that's why it's helpful with fibroids. Because sometimes if the fibroids are so big, the ultrasound may not be able to tell if it's an ovarian mass or it's a uterine mass or it's coming from the tube. So an MRI is a very helpful tool, especially for multiple and big fibroids. MRI is also helpful, especially when planning the management of fibroids. We'll come to that, but for example, if you are planning to have your fibroid removed through what we call hysteroscopy, it's basically robotic surgery where we pass a camera through your cervix into your uterus and we shave off the fibroid. So an MRI is helpful and very important in planning that surgery because it can tell us the exact location, the number and the size of the fibroids before we take you into theater. Management of fibroids, I think this is one of the most important questions that we have. So just a disclaimer, guys. Up ahead, I have some images of live patients that I've operated on in this month. So please brace yourselves. I hope it will not scare people away, but it's a look. Even if you go on the internet, these pictures are available, but these are actual patients that I operated on this month and took permission to share their pictures of the fibroids for teaching. So again, when we come to management, it depends on a number of factors. The desire for fertility, and if that is the reason you came to the hospital, if you have infertility, or if you're done and you came with other symptoms. And then also premenopause versus perimenopause versus menopause. So what I mean by this premenopause is, so menopause can happen anytime between the age of 45 to 55. Premenopause is patients under 45 who are not anywhere near menopause. Perimenopause is when your periods start misbehaving and you fall in that age group, and you might hit menopause anytime, but you're not there yet. Menopause means you have gone 2 years without seeing your periods and you're in proper menopause. That's classified as you've hit menopause. So menopause is a diagnosis you made in retrospect that, okay, now I've hit menopause, I have not had my menses for 2 years. All these will affect what options we give you for the management. So we have the medical management. For example, if you're a patient who, you are not looking for a pregnancy anytime soon, but you're having these heavy periods, you're having these painful periods that are affecting your daily life. There's some people who come to me, they cannot even go into work while they're on their menses because of the pain and the heavy bleeding. Or if you're somebody who it's affecting you even in terms of your blood level, it's decreasing your blood level to the extent that you're anemic. And anemia itself has its own signs and symptoms. You feel lethargic, you're slow at work, you don't have that energy to do anything, any strenuous activities. So for those people, again, we might eventually end up in surgery, but as a short-term method, if the symptoms are not too severe, you could use COCPs. COCP is combined oral contraceptive pill. Now, you can use this at any age, at any gestation, unless you have any underlying medical conditions like, for example, high blood pressure, because combined oral pills will have estrogen, which may not be safe in certain patients. So if you're just, if you have very small fibroids and it's just a matter of the pain and maybe some heavy bleeding, yet it's not bringing you so down to bring your hemoglobin low, we could consider oral contraceptive pills, with the last option there being tranexamic acid. Tranexamic acid is an oral medication that basically reduces your bleeding. So we recommend that on the second, from your first or second day of your periods for a couple of days. It will reduce the volume of your bleeding. Now, a management option that I really love is called the progestin releasing intrauterine device, which is also known as a Mirena. This is like, what in layman's terms people know as the coil. It's a family planning intrauterine device, or coil as people know it, but it has a hormone. It has a progesterone hormone inserted into the device. So the advantage of this is you insert it through the cervix into your vagina, through the vagina into your cervix, into your uterus, and it sits there and works locally. So the effect of the hormone is basically mostly on your uterus. Very minimal amounts of hormone will enter your body, and so you don't have the systemic side effects of oral hormonal therapy. And this method is good for patients who've already, conceived and have babies. They're not looking, or single women or young girls who are not looking for a pregnancy anytime soon, because it can go for 5 years. When you want a baby, the device is removed and return to fertility is almost immediate. The other option is high-dose oral progestin, which I'm not a fan of because it comes with a lot of systemic side effects. So those are the oral medication. And then you have the GnRH antagonists or the GnRH agonists. So the antagonists are also oral formulations. They are fairly new mode of treatment. And so both of these medications, they have hypoestrogenic effects. Two things. If you have a patient who desires fertility and do not want their fibroids, their uterus to be removed, you could offer them any one of these options, because they basically reduce the size of the fibroids. You have to do these medication for at least, I recommend 6 months. Some people will say 3 months is good enough. They come with their side effects, of course, because they mimic menopause, especially the GnRH agonists. These are monthly injections. You need to come in every month for an injection for 3 to 6 months. Again, if you have a patient who is, let's say, the age of 50 and she's presenting, you have the abnormal bleeding a little bit on the higher side, you could try this medication, because it shrinks it a little, shrinks the fibroids, and if they shrink them away from the area causing the disease in terms of bleeding or pain, you may really benefit. And this is a preferable option for smaller fibroids. However, if you are somebody who is experiencing pressure symptoms, you would benefit from surgery as opposed to this, and so this is pre-operative. That's why I've written it there. Can be done pre-operative. So if you have somebody who has really big fibroid, but she wants to conserve or preserve her fertility, you give them this option. We shrink the fibroids a little bit, then we take you to theater, or as you're building up your hemoglobin, and then you go to theater. Or somebody who's perimenopausal, this is also a good option, because you might hit menopause in a couple of months or in the span of 1 year, and so you would not need any further management. There is another option called uterine artery embolization. This option is suitable for premenopausal women who do not desire future fertility. So basically, this is done by interventional radiologists, not by gynecologists, whereby they pass in a catheter through your blood vessel and they embolize. So basically, they introduce a clot into your uterine artery, which stops the flow to the uterus. Okay, and so in this way, it stops the flow to the fibroid, and you will not be getting your periods. It basically stops your uterus from functioning. There is a high-tech, advancements in management. There's something called a focused ultrasound surgery. This focused ultrasound surgery, it utilizes high-intensity ultrasound energy to induce coagulative necrosis of fibroids. So basically, necrosis means dying of cells. So what they do is they focus the ultrasounds on a specific position where the fibroid is, and they target this high-energy ultrasound to that point, which helps in, so to speak, it makes the cells die off. And so it causes necrosis of the fibroids. It's a good option, especially if they're not that many in number. In China, it's usually, they use ultrasound, and it's called HIFU, or MRI in the rest of the world. In Kenya, I do not think we have HIFU yet. I have not seen any center that is doing it for the time being, unless Aga Khan has started. I'm not too sure. But I know for our place, we haven't yet started the HIFU as management option. So again, this is not a good option for very big fibroids causing pressure symptoms, because again, how much will you, it's recommended actually for less than 10 centimeter in total size of the fibroids. So you might have 10 fibroids, but all 1 centimeter or less than a centimeter, and you could still use this option. Or you might have one fibroid which is 12 centimeter, and this option is not, you're not eligible for this management option. This is another method called endometrial ablation. Again, this is not very commonly used for fibroids. What they do basically is, sort of in layman's terms, they burn off the endometrial lining, so there's nothing to bleed, basically. Again, this is not helpful for very big fibroids, because they may be causing symptomatic pain, pressure symptoms, which this method will not really help you for that. Okay, so we come to surgical management. Again, I said we're going to have some graphic pictures here. So, if you are somebody who's not used to looking at blood, please put your phone away and just listen to my voice. So we have two options. We have the minimally invasive surgery, where we have laparoscopic and hysteroscopic myomectomy. Myomectomy basically means removal of a fibroid. Laparoscopic means it's another name for laparoscopic is keyhole surgery, whereby we make an incision on your umbilicus, what we say kitovu, and we pass a camera through it. And the single port entry or multiple port entry, we have single port entry available in Kenya nowadays as well, where they just make one cut and introduce all the instruments through that one cut. On the other hand, we might introduce a small 1 centimeter cuts, or depending on where we are operating on, in your lower abdomen or higher abdomen, small cuts that, when they heal, it just looks like a scratch. And so we go through your abdomen and we cut off the fibroids and remove them through these ports. We need to shred them and bring them out. The other thing that is from above, okay? Hysteroscopic myomectomy, I touched on it when we talked about the MRI. You have no cut on your body. This one, we are entering from the vagina through to the cervix. We just dilate your cervix with dilators. We're not cutting anywhere. We enter your uterus and we shave off the fibroid, especially if it's more submucosal. If you can remember the first slide, the slide in the beginning of the presentation, where we had the location. If it's submucosal, hysteroscopic is a very good option. Then open surgeries, if your fibroids are, so the recommendation is if your fibroids are more than 20 weeks, laparoscopy is not a good option. 20 weeks means 20 weeks of pregnancy. And why this is because, they may be very big, they may not be able to, it might take very long for the surgery. And so open surgery is recommended, whereby we make a cut in your lower abdomen. I personally prefer going through the same cut that they make for a C-section. And then we open your abdomen and we go in and we remove the fibroids through there. So the other option is an open total abdominal hysterectomy. This means we're removing your whole uterus. This is a good option, especially if you have achieved your desired fertility, your desired family size. And because, as you know, you might even just be 35, you have 3 children or 4 children, and you're done with your family size. If you opt for just removing the fibroids, you should know at the back of your mind that they will grow. They will continue growing until you hit menopause. So we offer the TAH option, especially for women with really big fibroids, because then we know you're going to bleed a lot. I will show you a picture of a uterus that was, we will talk about it as we get to the pictures. And so that's a good option because it will continue giving you pressure symptoms. Even if we remove all the fibroids, you will bleed a lot. So the surgical outcome is also a bit, in terms of recovery, it may take you longer if we just opt to remove the fibroids. So if you have no need for your uterus, we can offer you the option of a total abdominal hysterectomy where we remove the whole uterus. Now, if you're far from menopause, for example, if you're less than 50 and you've not hit menopause, we leave you with the ovaries. Okay, so it's very important you have this discussion with your doctor, because what brings menopause is actually the lack of hormones, not the lack of a uterus. In as much as you will not get your periods, you still get the benefit of the hormones that are being secreted by your ovary. So personally, I remove one ovary because, again, the ovary can develop cysts or other issues later on. But I always leave one ovary for the women who have not yet hit menopause to give them the benefit of the hormones that, estrogen especially. Okay, so this is a dish. This kidney dish is about 1.5 liters when full. So you can imagine how big these fibroids were. The largest fibroid was about 7 centimeters in size. And I think we removed a total of 30 fibroids from this lady. You can fill buckets. It's a crude joke, but they look like potatoes. And literally when you remove, you can imagine this is I think this is a 7.5 to 10 liter bucket, and it's almost filled it to the 3/4 way. And this is all from one patient. Now this is from another patient where we removed the whole uterus. You can see a pedunculated fibroid at the top. You can see these fibroids even in the, you can't even see her tubes or ovaries because the fibroids had taken over the whole uterus. And this is quite big. It may look small in the picture, but I mean, for reference size, it was the size of, let's say, between a medium to large pizza. I know that's a very crude comparison, but I feel like pizzas everybody eats. So this is the size of this uterus between a medium and a large pizza. It was a very big fibroid causing a lot of symptoms to the lady. And what you see down below is actually the cervix of the patient. So this is a summary. I feel this is very important. So if you have fibroids, it depends where the fibroids are, okay? If it's in the body, if it's symptomatic, you see the level of symptoms, whether this patient qualifies for medical or surgical management. If it's surgical, you can have endoscopic resection or a hysterectomy. Hysterectomy means your whole uterus is removed, or a myomectomy. Endoscopic resection is what we were talking about, the hysteroscopy versus the laparoscopy. If you have asymptomatic fibroids, you do a regular supervision. You might come in for review every 6 months to 1 year. You might still do surgery, but I mean, if they're not too big, we usually leave them alone. So if it's in the cervix, if it's supravaginal, you might consider myomectomy or hysterectomy again. If it's you might do a polypectomy where you just go from the vagina and sort of you twist it out. All right, so that's it for my presentation. I hope I did not use too many technical words. Thank you for your attention, and these were my references.
Thank you so much, Dr. I think I saw a few people drop out given the gory pictures. I hope that they have covered by now to actually ask the question. But we do have a couple of questions in the chat session, so allow us to just dig right in. So Ruth is asking, is there a possibility of the fibroids reoccurring after the surgery? Is there a possibility of the fibroids reoccurring after the surgery?
So definitely, as long as you're in the reproductive age group, which is between, I mean, basically until you hit menopause. Like I said, even if you're 30 years old and we remove the fibroids, they can keep growing back because these are microscopic things that are going on in your uterus, and we might not be able to, in as much as we remove whichever ones we see, we may not be able to remove the microscopic because we can't see them. And so they continue growing. Or even if they're not microscopic, even if we've removed all your fibroids, it's genetic. And as long as the estrogen is there, as long as the uterus, the hormones are there, they'll keep growing. So for a younger age group, I mean, it's important if we're doing, especially if you want to conserve your fertility, myomectomy is important if it's giving you so many symptoms. You might consider it before you even try to get pregnant because it can cause miscarriages.
Okay, thank you so much. I hope that your question was answered very well. So I'll now start from the top as I go down because I see there are more questions coming in.
Okay.
Are there side effects on taking tranexamic tablets, at least 6 tablets per day for the least? Just let me take that again. Are there side effects on taking tranexamic tablets, at least 6 tablets per day for 5 days during the heavy flow? Are there side effects for taking them at least 6 days, I think during the 5 days of the heavy flow? If I think your period is 5 days and you're taking them for 6 days, are there side effects?
So to be honest, I would not recommend long-term use of tranexamic acid because it can cause a clot formation. So yes, if you're using one tablet, they're usually 500 mg. You can do one tablet 3 times a day. The idea is not to stop the flow. So 500 mg is usually sufficient. And you can use it for 3 to 5 days, yes, but with caution. More than 3 days use of tranexamic acid increases the risk of you to get a clot in another part of your body.
Oh, wow. I think the participants might need to be a bit careful on that. Helen is asking, how long can one take the oral contraceptives as a treatment for fibroids? How long?
So basically, it's not necessarily a treatment for fibroids in the sense that it may not reduce them much, but it will reduce your symptoms. It will reduce the bleeding and the pain. So as long as you need, as long as you don't want a baby and it's working for you, you can take oral contraceptive pills even for 5 to 10 years. I mean, there's no cutoff that you can only take it for 3 months or 6 months. There are patients, I have them on it because they're not looking for a baby anytime soon. They have been on the pills for even 2 years, 3 years until they're ready for a pregnancy.
Thank you, Dr. The next question is, I know you've really talked about menopause, perimenopause, and all that. So the question is, do fibroids shrink when one hits menopause? Do they shrink?
Yes, they do. But like I said before, so if they're very small, you wouldn't need to worry about it. But if you have a uterus that is the size of a 7 or 8 month pregnancy, okay, and that is like all the way up to above your umbilicus, that's a huge uterus. So in as much as they do shrink after menopause, they shrink at a very slow rate. So you may still need surgery if you're having pressure symptoms. But yes, if you are having bleeding symptoms, those ones will disappear.
Okay, I think you had answered this question when you were sharing the photos. What is the size of big fibroids? I think you mentioned something about 20, I think 20 something, but I think you can just repeat that again. But the participant wants to know what's the size of big, quote unquote, big fibroids.
Well, that's very relative, I guess. Like I said, if it's so big that it's able to be felt on your abdomen, then I would classify that as big fibroids. So it may not be one fibroid, it may be so many that are like 2 centimeters, 3 centimeters, but it has made your uterus so big as to be able to be felt through your abdomen. And that signifies a 3 to 4 month pregnancy. So, I mean, it might just each fibroid might just be 2 centimeters, but because there are so many and able to palpate your uterus. So I think the question should be, what is the size of a big, I mean, what would make it big enough would be the uterus, not individual fibroids. Yes, if you have a fibroid that's 10 centimeters in itself, that's a big fibroid. But again, you might have one fibroid which is 5 centimeters and it's not causing you any symptoms. So you might not classify that as a big fibroid per se, when actually 5 centimeters is quite significant. But if you have multiple 5 centimeter fibroids and they make your uterus so big, then yes, that would need intervention. I hope that answers the question.
Yes, it does. I think if you're able to also see the the nice photographs, you'll see that I think they vary in sizes. It's just what you're saying. They fill up the whole entire uterus. So it doesn't matter whether it's 2, 5, 10, all in the same, all in the same uterus. The other question is, and I know you have really talked about surgical remedies, contraceptive remedies. So the particular participant is asking, what are the natural remedies or ways to manage the fibroid?
So there's no natural remedies. Well, you might say natural in terms of your symptoms. So if you do a hot water bottle or warm tea during your menses, if you are somebody who experiences painful cramps, had low HP, natural remedies would just be now things to increase your hemoglobin content. So there's no specific medication or habits that you can do that will reduce your fibroids. I get this question quite a bit. And patients are like, what can I do for them not to grow bigger? Or what can I do so that they don't recur after surgery? Unfortunately, there's nothing we can do because it's genetic. It's inbuilt. It's basically, if you're going to have, for example, eye color of your baby is going to be brown, and there's nothing you can do to change that. It's in the genes.
Okay. Yes, it does. Yes, it does. I think I have a further question from my end. I think one of the things that she said that also causes fibroids is the high levels of estrogen, I guess. Are there ways to manage it? The same way you're talking about the hemoglobin, are there ways to manage the high levels using, let me say, natural methods, I guess? Are there ways to?
Yeah. Some people talk about maca powder, but again, there's not much research that has been done into it. So, I mean, anything that will basically these other remedies would have a bit of a harmful effect to the rest of your body. Like I was talking about the beneficial effects of the hormones that are coming from your ovaries, one of them being estrogen. And so anything that suppresses that would, in an unchecked level, like a natural way, I would not recommend, because then it would mean a herbal medication. And herbal medication, to be honest, sometimes they may not standardize the level of hormone or anti-hormone in it, and it can lead to severe side effects later. So, I mean, I would recommend that you come in. If it's to do medication, we have the GnRH analogs that we were talking about, both the oral and the injectables.
Okay. So I think one question that has been asked here, you have already answered, but I want to tackle his first question. What are the specific risks of not treating fibroids, and how might they impact my overall health in the long term? So if this goes untreated, what is the long-term impact to one's health?
I think, yeah, like you said, we discussed this. It depends on symptoms. You might have no symptoms, and there's no long-term effect. So one thing to note, we didn't talk about this, I don't have a slide on it, is that 0.1% of fibroids will go to cancer. So you see, it's a very, very low percentage. So that's the only thing that you would think. But if you're not symptomatic and you have, for example, 2 fibroids that are 2 to 3 centimeters, you have normal menses, you have no pain, you have babies, you have, and there's no symptoms, nothing will come out of us not treating them. They might grow, but again, the size, how fast they grow is again genetic. So if you're 40 and your fibroids are 2 centimeters each, they're unlikely to grow to such an extent to cause you symptoms in the next 5 to 10 years. Because you've been having periods for the past, let's say, around 30 years. And in those 30 years that you've had only 2 or 3 fibroids, you might not have any long-term effects. However, if these things are causing you symptoms, they're causing you anemia, it will affect your day-to-day life. It will affect your energy. It will, if you're having pressure symptoms, if you're having constipation because of the fibroids, it'll give you what we call piles, hemorrhoids. So based on what symptoms it's giving, if it is giving you symptoms, you need it treated. Definitely you need it treated.
Okay, I can't see any other question, because I know that you had answered this question on what are the chances of fibroids returning after treatment, which you said really there's no guarantee per se that one can be given and told that they're not going to reoccur. And
Yes.
How can we minimize that risk? I think we really tackled this question. So I will not get back into it. So I would want to give you your accolades, let me call them that. So Betty says, thank you, very good and clear presentation. Somebody else is also asking, can Dr. Sauda share her contacts? Please do that in the chat session as well, Daktari. And somebody really wants to have a session on menopause symptoms. Maybe you can give them a teaser in terms of management of menopause symptoms. Just a teaser.
Yeah, so I've sent my number in the chats, but I may be very bad at answering calls. So please do text me. Yeah, I'm very active on WhatsApp. And in terms of management of menopause symptoms, so it's basically lack of estrogen. So all the symptoms we are having, without the estrogen, you'll have the hot flushes, you'll have dryness down there in the vagina, what we call hamu ya sex, imenda chini. So, there's many ways we can manage. Now, this one you can do dietary. So we talk about soya. If you saw the presentation, one of the risks of getting fibroids is soya products. So now menopausal symptoms can be treated by soya products. So you can do soya milk, soya chunks, soya bean, 2 to 3 times in a week. It helps. However, I would recommend menopausal symptoms is a very vast topic, of course. It has a lot of underdiagnosis in it, and people saying, it's normal. I have a lot of patients who are depressed actually and who needed assistance but did not get because it was just sidelined. So I would recommend to the team, if there's anybody you know or yourself who's going through menopausal symptoms, please do come in. There are also medications that we can give to help your symptoms and to help your quality of life.
Thank you so much. I think the other question is, Somebody's asking which hospital you're attached to. So I think they didn't read the poster very well. But nonetheless, somebody is asking as well, do you have special rates for this October Cancer Month for pap smears, etc.? Maybe you can speak a little bit on that, Daktari. Before the end of the month, we are shy by 8 days.
Yes, so October is a Cancer Awareness Month, and I think Nairobi West is offering a subsidized rate on the pap smears. Usually they go for 3,800 per pap smear, and from what I understand, it's going at about 1,500. But I will share, if I can have Annette's contacts, I will share the poster that we have on what is under, what is under offer, so that you can share it with the team. I think they also have an offer on mammogram, if I'm not wrong, maybe 2,500, but I stand to be corrected. I will share the poster.
Thank you so much, Doc. I don't think I can see any other question. And you have answered the question whether you're attached to a certain hospital. For the participant who did not read the poster, that's Nairobi West. That's where you can find her. And please do WhatsApp her. As she said, she's really bad with calls. I think one final question. Do fibroids cause menses to stop? Do they stop?
Not especially, specifically the fibroids, they do not cause menses to stop, because unless there's a blockage somewhere, if you have a cervical fibroid that is blocking the outflow, so it might not stop the flow because of hormones. It may just mechanically stop it from coming out, but otherwise it has an increase in period of flow and pain. It doesn't, it never actually stops the menses because of the hormones or the location of the fiber. Unless it's cervical, then it will be more of obstructive, stopping the flow.
So I cannot see any other question on the chat session. I'll leave it at that. Unless there's any participant who would like to unmute themselves and ask their question. And I keep saying I like to do this like the auctioneer's hammer. Going once, going twice. You're waiting for 30 seconds. Going thrice. Unfortunately, the hammer is down. Thank you so much, Dr. Sauda, for taking the time to take us through fibroids. I know there will be further questions, and also the recording of this particular webinar will be shared among the participants. So much that we have learned today. I do hope that the participants as well can echo my sentiments. From our team as well in Jogwe and Associates, we have also learned a lot, and especially how to, support an employee who's also going through or has this condition of fibroids. Sally is now back. She will not allow us to close the question session. So I'll just indulge Sally before we say goodbye and good afternoon. Sally says, I used to have very heavy menses because of fibroids, but they have stopped coming. So I think Sally's question was actually saying the fibroids actually stopped my menses from coming.
Unless she's hit menopause, it's not because of the fibroids. So that's why I'm asking, how old is Sally?
Sally, do you mind sharing the ranges? Daktari gave us ranges. Oh, wonderful. 38.
38. That's too early, Sally. It could not, it should not, you should not stop bleeding at that age. You need to come in, we check you, we do some tests to find out what's going on, why you've hit, why you're not getting your periods, because it is not normal to stop getting your periods at the age of 38 unless you're on a family planning method, like especially the implant or the monthly the 3 monthly depot injections. They can make your periods stop. So if you're not on any family planning, you need to come in to get checked, because 38 is a very young age to stop getting periods.
All right, so I'll close it at that. I can't see any other questions. But as I said, Daktari, thank you so much. And thank you to all the participants who have had made time to actually participate in this webinar. I do know that you have learned something. And if you do need to see Daktari, as she said, please do send her a WhatsApp message. And she's found at Nairobi West. You can pay her a visit at your own convenience and take advantage, of course, of the October rates for Cancer Awareness Month. So thank you so much, ladies and gentlemen. Allow us to close this. Thank you so much, Daktari. Thank you, Team Joku. Do have yourselves a good afternoon.